Hello, welcome ladies and gentlemen to today's tutorial. Today we are going to look at the uterus. Of course, the uterus is commonly referred to as the womb by the layperson. Yes, it is going to be associated with the uterine tube, which you can also call it the fallopian tube or the sapiens because trumpet shaped. Now this uterus is roughly pear-shaped like an inverted pear, and apart from being the site where implantation would take place, it is also going to nourish this implanted embryo. Apart from, yes, providing some kind of nourishment, yes, it's also going to have its neck, which is referred to as the cervix or the cervical part of the uterus. Now this cervix, yes, will actually will make some secretions which will actually lubricate the vagina to ensure that there's less friction. Now we've already indicated that the vagina is aglandular. It doesn't have glands, and for that matter we learned that the Bartholin's gland, yes, will help provide some lubrication. Some secretion will be provided into the entrance, the introitus area of the vagina. Then of course, as sexual intercourse goes on, yes, further lubrication will be coming from the uterus through its cervix into the vagina to lubricate it. Yes, this same cervical portion will be very important regarding the serving as the lower part, sorry, upper part of the birth canal. Now we said that the birth canal mainly will be contributed by the vagina, but of course the upper portion of the birth canal will be coming from what we call the cervix. Now monthly females will go through shedding of blood periodically, which we call it menses, the menstrual blood flow. It's actually be coming from actually the shedding of the functional layer of the uterus, which we are going to look at that one. We are going to look at it. So that is what we are going to see. So let's begin our journey with this. Now, so this is the uterus. We said that it's roughly pear-shaped, okay, like an inverted pear. Now, as we will see later, you get to know that it's going to have, from the lumen of the uterus. And so from the lumen, we are going to have endometrium, that's the mucous membrane, mucosa of it. And then we are going to have the myometrium, a very muscular organ, myometrium. So that under the influence of oxytocin during labor, it can help in various uterine contractions to expel, the uterus. Then we're also going to have, of course, the perimetrium. So these ones represent the coats or the tunics of, the uterus. Now, one thing that we have to know is that the uterus will roughly, yes, in a non-gravid female, in a female who hasn't given birth, or who is not pregnant actually, yes, who weigh, the uterus will weigh around 60 grams. But due to hypertrophy and of course hyperplasia, mainly hyperplasia, yes, as a result of pregnancy, then the uterus will its weight will actually increase to up to about 1,000 grams, because around week 15, week 16, it's roughly 500 grams, but at term we expect that the weight will be around 1,000 grams, and immediately after delivery, then what will happen is that it will still be around 1,000 grams, and then later there will be atrophy happening in there to reduce its weight. But of course it may not necessarily come to 60 gram, it may be around 70 gram. Okay, so that is what we are going to find with the weight of the uterus. Now, one other thing too that you have to know is that what's the capacity of this uterus, that was the volume that it can contain. Yes, in a non-gravid female, yes, its volume will be just around 10 mils. Okay, its capacity will be just about 10 mil or 10 centimeters cube. But in gravid female, it will be around 5,000. It can extend up to about 5,000 mils. Now regarding its dimensions, it's roughly 8 centimeters long. Yes, roughly going to be 8 centimeters long. Or a range of 7 to 9 centimeters long. Then with its width is going to be, yes, roughly around 5 centimeters long. And of course its thickness will be just around 3 centimeters thick. So that is what we find with the dimensions. Now this one is regarding a non-gravid uterus. Of course, there will be changes if pregnancy, the lady has conceived, okay, in here. If there is fetus or embryo in here, then the dimensions may change. Now, having seen this, now you look at this uterus. It's actually an organ where it's located in the pelvic cavity. Now you realize that it is sandwiched between two main organs. Okay, posteriorly it is related to the rectum, and then anteriorly it is related to the urinary bladder, where is the cervical organ, the vesical organ. And therefore there are some peritoneal reflections which create some pouches around over here. Now these pouches represent potential spaces for accumulation of infectious fluid, okay, in the female pelvic area. So over here, the deeper one, which is over here between, of course, the uterus and the rectum, is known as rectal uterine pouch. Rectal uterine pouch, which is also known as the pouch of Douglas. Now this is the posterior cul-de-sac in, or space or pouch in that of females. Then we also have an anterior cul-de-sac, which is less deeper, or is quite shallower compared to that of the posterior cul-de-sac. This anterior cul-de-sac is between, of course, the uterus and the urinary bladder. Therefore, we call it, the vesical uterine pouch, vesical uterine pouch, or utero-vesical pouch. So, that is that for you. Now, you realize that we explained that, yes, of course, when you get there, I will explain, give more detail. We explained that, of course, if the vagina over here is just serving as a cup, so that it can receive, of course, the uterus. Now the uterus, as it receives it, the one which enters it is actually the cervix, which we are going to see it in greater detail. Now remember that we also indicated that this is the external genitalia, being the vulva. As you can see, this is actually a sagittal section, so through the pelvic area. So we can see the labium majus, where you can see here. Yes, of course, the mons pubis will be here. Yes, you can also see the labium minus. Yes, you can see the clitoris, over here. And then, of course, we said that connecting the vulva, or the external genitalia, to what we call the uterus, to actually the internal organs of the female, mainly the uterus, will be the vagina, So that is what we actually, explained. That's what we actually explained. Now, normally, for the position of the vagina, we say the vagina is antiversed, okay, and it's also antiflexed. So what do we mean by the antiversion? Now, this is the vagina. This is the vagina. This is the neck of the uterus, being the cervix, and this is the body of the uterus. Now, if I take an imaginary line through the long axis of the vagina, okay, this way, and then I take an imaginary line through the long axis of the cervix, okay, then we will say that the vagina is antiversed, such that the long axis of the cervix and the long axis of the vagina will make an angle of 90 degrees. They will be perpendicular to each other, and therefore we see the vagina is antiversed. All right, now if it is antiflexed, then it is actually related to the long axis of the cervix, as well as the long axis of the uterus, body of the uterus. So when we have such a phenomenon and we take the angle over here, this angle, which is found between roughly 120 degrees up to about 170 degrees, okay, this angle gives us what we call the antiflexed angle. So whenever we talk about antiflexion, then it has to do with the cervical portion and the body of the uterus. So they are long axes. All right, so that is what we find. However, yes, talking about the normal positions of the uterus, there could be other abnormal position. Now there's a normal position. Now you can see that here is the rectum, here is the urinary bladder, so that we say that this is the antiversed position. okay, anteverse position, so that yes, I mean the body is moving towards where we have the pubic, symphysis, okay, not to the rectum. Then when it is anteflexed, then we said it's between the long axis of the, the cervix and the long axis of the body of the uterus, making that kind of, about 120 to about, 170 degrees angle. Now, if you have such a thing, if the cervix is involved, you can also see that that one is known as the anteflexed, position, anteflexed position. Now, when it is retroflexed, okay, when it is retroflexed, then we say that it is tipped. The uterus is actually tipped, backwards at the cervix, flexed position. So the cervix is involved, as you can see, tipped towards where we have the rectum. Now, if the cervix is not involved, okay, then we are going to have, also tipping towards, where we have the rectum. Then we say it is, retroversed. Then we can have a combination of both retroversion and then, of course, retroflexed, position. But one thing that I want to say over here is that, yes, with the retroverted position, then what will happen is that it's quite, painful when you have sexual intercourse, from the backside, okay, like, the doggy style. If such a case, then the female may be feeling, a lot of, pains, okay, retroverted, position. Why? Because the support ligaments of the uterus will actually be, stressed, will be stressed, and leading to that kind of pain during, sexual intercourse through, of course, the doggy area. Then, of course, that won't help, of course, the female. So that is with the positions of, the uterus. Now, we've seen the uterus. We said that the uterus is pear-shaped, like an inverted pear. Yes, it will have a cavity, and that's the uterine cavity, which is roughly triangular shaped. Then we've also seen the coats. It's going to have 3 coats, of course, endometrium, myometrium, and of course perimetrium. Now, when you look at it at the superior aspect, we have some junctions, okay, where of course the uterine tube will be inserting. This area, apart from the uterine tube, there will be other structures which I'm going to take you through pretty soon. It's known as conus of the uterus. Conus of the uterus. So plural is conua, or they represent the horns of the uterus. Horns of the uterus. Now, if I take an imaginary line from where I have the fallopian tube inserting, so that's the conus, all the way to the opposite aspect, then what will happen is that superior to this imaginary line will be this fundic area. Okay, will be this dome-shaped region, which we call it fundus of the uterus. Fundus of the uterus. Now, it's actually the fundus of the uterus, the posterior aspect of the fundus of the uterus, where normally we expect, implantation of the embryo. Any other place, okay, may lead to what we call intrauterine, ectopic, pregnancy, which, we are going to see that, which of course we also call it placenta previa. So that is it. But, having talked about the conua, then there are 3 main structures which I have to explain. So from superior to inferior, I'm going to have what we call the uterine tube or the fallopian tube, or the sapiens. Then at the inferior aspect, there will be 2 structures which will relate to the same level, which will be the ovarian ligament, as well as, of course, the round ligament of the uterus. Now, this is actually the posterior view. Now, these structures, you could also be asked to arrange them from anterior to posterior or vice versa. So from anterior to posterior, we are going to have, of course, the round ligament of the uterus, followed by, of course, the uterine tube, and then the posterior most structure will be the ovarian ligament. So these are how the structures relate at the level of the conua. These structures are all going to be related to the conua. Now, I said that, yes, this imaginary line above here is the fundus. Now, below the imaginary line, we are going to have what we call the body of the uterus. The body of the uterus, or the corpus of the uterus. Now, beyond that will be this narrow area. So that's where we have the cervical canal. Will be the cervix. Now, in between the body of the uterus and the cervix, that's the neck of the uterus, we have a narrow area which we call the isthmus. So I'll actually explain the isthmus better, okay, in another slide. Now, what we are going to find is that, yes, if I want to move from the vagina, okay, this is the vagina, into the cervix of the uterus, then I have to go through the ostium, okay, ostium, which specifically we are going to call it, the external cervical os, or the external orifice, external os. Then, if I want to actually move from the cervix into the uterus, then I'll have to also go through what we call the, internal cervical os, or the internal os of the cervix. So that is what we are going to see. Now, we are going to find other things which I'll actually explain, but look at this, giving some kind of partial support to the uterus, okay, laterally, we are finding this tent-like, double fold of peritoneum, where you have neurovascular structures entering, the uterus, as well as, the associated areas like the uterine tube, is known as the broad ligament of the uterus. Now, the broad ligament is going to have 3 parts, but of course, some authorities say there are 4 parts, so I will actually go by the 3 and 4. So if there are 3 parts, then we are going to have what we call the parts which is attached to the body of the uterus, and it's known as mesometrium. Then we're going to also have the part which is related to the uterine tube, or the salpins, and therefore we call it the mesosalpins. Then we're also going to have those parts which should be related to the ovary, which we call it the mesovarium. So these represent actually the components of the broad ligament if there are 3. But if there are 4, then we add what we call the infundibulopelvic ligament, which is otherwise known as suspension ligament of the ovary. And within this suspension ligament of the ovary, will run some neurovascular structures, mainly the ovarian artery and of course the ovarian vein, okay, to give some supply to, of course, the ovary together with, the lateral third of, the salpins. So you actually see all those things. Now, regarding, ligaments, which are going to provide this kind of partial support to the uterus, yes, apart from the broad ligament, you have to also know that we are also going to have the round ligament of the uterus, will also provide some partial ligament. Then there's another ligament which will actually span between the uterus and the, the sacrum, so which you call it the sacral, uterine ligament, or uterosacral ligament. So that ligament will also provide some partial support. Then, even apart from that, yes, we're also going to have the cardinal ligament, or the transverse cervical ligament, or the lateral cervical ligament, or the Markenroth ligament. Yes, will also provide some kind of partial support to the uterus. Now, one thing that you have to also know over here is that if you talk about the cardinal ligament together with the uterosacral ligament, we also call it the parametrium. So parametrium consists of cardinal ligament plus uterosacral ligament, parametrium. All right, now one thing too that we have to explain over here will be actually the blood supply to the uterus. So blood supply to the uterus will be mainly coming from, of course, the uterine artery, which is actually a branch of the anterior division of the internal iliac artery. Then, of course, it will be drained by, of course, the internal iliac vein. So that will be the blood supply to, of course, the uterus. But regarding innervation, yeah, the uterus will actually be receiving some supply together with the cervix from actually the T10 to actually the L1 levels. That will be sympathetic innervation via what we call the inferior hypogastric nerve plexus. And that is where referred pain during painful labor can actually be seen. So because this through the inferior hypogastric nerve plexus from T1 to T from T10 to L1 segments, by way of sympathetic innervation, also supply the lumbosacral area, the lower abdominal area, as well, of course, the loin, the loin areas. Therefore, if you are getting delivered, then what will happen is that there should be anesthesia to this, nerve. And usually we block it at the level of T10, vertebral level. T10, level is where we are going to, block it. All right, so that is with the, the vasculature, of course, as well as, the innervation. Now, regarding the lymphatic drainage, yes, mainly we are going to find the fundic area being drained by what we call the para-aortic group of lymph nodes. Okay, yes, even apart from that, yes, you can see this area is more to the interstitial parts of the uterine tube. Yes, it's actually getting, drained by what we call the superficial group of, lymph nodes. Then, even in the cervical region, yes, it's going to be drained by what we call the sacral group of lymph nodes, as well as, of course, the external iliac lymph nodes. So, and then even some may even drain directly into the internal iliac group of lymph nodes. So that's the lymphatic drainage regarding, the uterus. Now, when we look at the uterus, I'm going to show you the epithelial lining, but for now, you should know that the epithelial lining is actually simple columnar epithelial tissue. With these, glands. So that's the endometrial glands within the endometrium. Now, if we take the uterine tube, apart from the epithelial lining, we are also going to have this, connective tissue, loose connective tissue, which that's the lamina propria, okay, forming what we call the, endometrium. Then beyond that, we are going to have, the myometrium, okay, going to have 3 layers, which I'm going to explain pretty soon. And then beyond that, we are going to have the perimetrium. Now, if you take the endometrium is going to have, 2 main divisions. We are going to have what we call the functional layer or stratum functionalis, and of course the stratum basalis, okay, the basal layer. Now, during menstrual flow, it is the functional layer which is shed periodically every month. So this one will get shed if the ovulated oocyte, secondary oocyte, doesn't get fertilized. Then what will happen is that the decidual formation will have to be broken down. Okay, that's the periodic monthly shedding of blood. It will be coming from. So all this area will be shed, leaving the basal layer, which is regenerative, which will later give rise to what we call the basal layer. Now, I actually explain, from the uterine artery, we have other branches into these areas, which I'll get to. I'll explain that one pretty soon. All right, so that is the uterus. Now, if you look at the functional layer, the superficial portion is known as stratum compactum, the compact layer, and then beneath the deeper layer of the functional layer will be the stratum spongiosum. But remember, both of them will be shed during menstrual flow of blood. So there we are. As I said, this simple columnar epithelial tissue, and these represent the glands, okay, endometrial glands in there. All right. Now, good. Now, if we look at the uterine artery, yeah, there's some kind of anastomotic connection anyway with the ovarian artery. But from the uterine artery, we are going to get some kind of branches. Okay, uterine artery will give off this branch known as the arcuate, artery. And then from the arcuate artery will actually enter, the myometrium. It's actually in the myometrium anyway, the muscle area, to give off what we call the radial artery. So radiate from the arcuate, okay, giving it an arc over here, arcuate artery. Then of course radial artery, radiating from the arcuate artery. And then within the endometrium, we are going to have 2 areas. We have the stratum basalis and then stratum functionalis. The smaller stratum basalis will have mainly what we call the basal artery, okay, coming from actually the radial artery, and then there will be some coiled arteries, okay, also coming from there, and these are known as the spiral artery. Now it is these spiral arteries where, if no implantation occurs, will undergo spasm. Okay, there will become some kind of spasms, forming. Yes, of course, because the corpus luteum, which later we get to see, will be converted, into what we call corpus albicans, so that there will be spasm. Okay, it won't be getting, there'll be constriction and then spasms taking place, and then later it will get ruptured. Okay, necrosis will take place, breakdown to be seen as the menses. So remember that the menstrual flow of blood that we see is not actually the oocytes, which is giving us the blood. It is actually coming from the breakdown of the functional layer of the uterus. Now, good. Now, if you look at the myometrium is going to have 3 layers. So the myometrium is going to have 3 layers. It is going to have the outer longitudinal layer. It will also have the middle crisscross layer. Okay, middle crisscross layer. And then also going to have the inner layer, which often are arranged obliquely and, of course, longitudinally. Now, what we find is that, yes, because the outer layer, within the middle crisscross layer, there will be some blood vessels over there. So therefore, the outer, longitudinal layer will also be called the stratum supravasculare. Because above, where we have the blood vessels. Then the lower, the middle crisscross layer, or the interlacing area, okay, as you can see, will be, okay, you can see the interlacing layer, okay, wrapping around the blood vessels over there, will actually be the stratum vasculare, okay, stratum vasculare layer. Then, of course, we have the inner, layer, okay, inner layer, which will, of course, be the stratum, infravasculare. Now, what we find is that, yes, usually at term, when it is time for labor, what happens is that blood supply to actually the uterus actually increases, such that, yes, the cardiac output to the uterus will be about 15% of the blood, which is, being pumped by, the left atrium of the heart. So roughly about 500 to 800 mils of blood will get to the uterus per minute. Now, if this blood is coming, and of course, after delivery, this blood, yes, will also get to the fetus through what we call the uterine, vessels. If this blood is just too much in that manner, then what happens is that if just immediately after delivery, yes, there could be a lot of blood also coming out after, the placenta has been erupted. And that one will lead to, something we call postpartum hemorrhage. Therefore, the body, God has made it such that these blood vessels, okay, the uterine maternal blood vessels, okay, which are over here, are actually within, okay, the middle crisscross layers are actually forming a crisscross in several planes, yes, forming a crisscross, so that within these crisscross, we will find the blood vessels. So that upon contraction of, the crisscross layer, what will happen is that it can cause, it can occlude, the movement of blood, reducing the blood flow. Therefore, we call this, middle crisscross layer performing what we call living ligature of the uterus. It performs this living ligature so that it prevents, blood from actually moving out, without, so that we don't lose a lot of blood, So that's the living ligature of the, the, musculature of the uterus, myometrium. Now, we will actually look at the main organ, primary organ of the female reproductive system being, the ovary. But for now, what will happen is that, yes, there will be some follicles in the ovary. Yes, primordial follicle, we have primary follicle, secondary follicle. As the follicular growth occurs under the influence of follicle stimulating hormone from the anterior pituitary gland, then what will happen is that there will be follicular growth. Yes, eventually, into what we call the Graafian follicle, which will later release the secondary oocytes, okay, which we are going to explain actually, and then later it will be converted into a yellow body, a temporary endocrine structure, being the corpus luteum, okay, for about 2 weeks. But if there is implantation, then what will happen is that the trophoblast cells will secrete what we call human chorionic gonadotropin to continuously maintain this corpus luteum, so that we have the corpus luteum of pregnancy or corpus luteum gravida, so that it can maintain help in that regard. Otherwise, if no pregnancy occurs, it regresses to become a white body known as corpus albicans. Now, what do I mean? As follicular growth occurs, what will happen is that we have what we call granulosa cells, which we are going to get to. They will be secreting what we call estrogen, mainly estradiol, and this estradiol will actually prepare the uterine epithelium, the uterine mucosa, so that what will happen is that they will begin to increase in size. Then after ovulation, when this yellow body is formed, the corpus luteum is formed, then there will be progesterone production, which will of course lead to further increase of the glands. Okay, the tortuosity of the gland will increase, more glycogen will be formed in there. Okay, now if nothing happens, then after 2 weeks, the corpus luteum regresses. If no conception takes place, then eventually it will have to be broken down. Okay, the functional layer will have to be shed off. So actually in the uterus, we are going to find that we're going to have the menstrual phase, which will last 3 to 5 days. Some people have it up to about 7th day. Then we're also going to have the proliferative state, under the influence of follicle stimulating hormone, so that the uterus, okay, the follicular cells, granulosa cells of the follicles, will be producing what we call estradiol to prepare the uterus. So you can see the uterine glands will be increasing. Then after ovulation, what will happen is that, yes, ovulation, corpus luteum will be formed. Corpus luteum formation will lead to formation of more progesterone. So as progesterone is formed, then it becomes even more tortuous. In anticipation that around the 14th day, ovulation should take place, the oocyte should get fertilized, okay, by a sperm. All right, so that's for you. Now, if we look at the uterine cycle, as I've already hinted, we are going to have the early proliferative state. It's under the influence of follicle stimulating hormone, but actually the hormone which is going to help cause increase in glandular formation of more glands will actually be coming from the estrogen, estradiol. So you can see that the glands have begun forming. Then at the late proliferative state, as more estradiol is produced, okay, from what we call the granulosa cells, then the glands become even more tortuous, and they'll become more larger, and then they become, they start, mobilizing what we call glycogen, as you can see. Then you can even see that, the pits, you can see they are quite tubular. Okay, you can see the tubular glands. Then around the secretory phase, they begin to make secretions, this kind of secretion, which is, actually rich in glycogen, Okay, so that is what we are going to see in anticipation that there should be implantation. Okay, that's what we call decidual formation. There will be decidualization generally. But if no pregnancy occurs, then after 2 weeks, what will happen is that the corpus, luteum will be regress, and then of course there will be spasms in the spiral vessels, okay, in the functional layer of the endometrium, leading to rupturing of the blood vessels, and then of course the blood will clot, and then later everything will get regressed and it will be broken down, which will come as menses. But just to tell you something, it tells us that immediately after the menstrual phase, then what will happen is that early proliferative phase will begin, or general proliferative, which will later come to the late proliferative state. So it tells you that the proliferative state is actually a repair phase, and it usually lasts for about 9 days. But of course, as I said, it's actually represent the follicular growth. So in the ovary, which we'll get to, you see that the follicles will be growing in that manner. And over here, the thickness yes, this one will break down, and over here in the proliferative state, the thickness will actually increase about twice or thrice, actually, as you can see. And actually over here too, yes, the spiral arteries will actually elongate. There will be elongation of the spiral arteries, so I mean, that's what we are going to find. Yes, I've told you that in the secretory phase, yes, a lot of glycogen rich material will be secreted, and it will actually last for about 13 days. But even with this, there's further thickening of the uterine endometrium. Now usually the menstrual cycle doesn't really have a lot of effect on the myometrium as well as the perimetrium. It's just actually the endometrium which has this kind of changes. Now remember that this one is happening in the body of the uterus. The cervix really will go through some kind of changes with the menstrual cycle, except of course with that of kind of this kind of mucus consistency just may change regarding that one. The mucus will be less thick or be less viscous, especially during the ovulatory phase, so that it can help in easy penetration by the spermatozoa. Now, having talked about these kind of bleeding regarding menstruation, then there are some key things which we have to explain, and one of them is known as amenorrhea. When we talk about amenorrhea, that's absence of bleeding at all, and this amenorrhea, okay, is related to what we call amenorrhea, absence of bleeding at all, so that no actually blood actually comes out. There's no preparation of the uterus in anticipation for any possible implantation. And usually if someone goes through family planning method, then of course the person may not bleed monthly, and that condition we call it amenorrhea. Or it could be some kind of chronic disorder which the person is actually facing. Now the other one is known as dysmenorrhea. Now for dysmenorrhea, that one is irregular painful menses, irregular painful menses. So painful menses will be happening in there. And if someone presents with fibroid or pelvic inflammatory disease, there could be some kind of this menorrhea actually. Then we can also have what you call menorrhagia or menorrhea or hypermenorrhea, and this one has to do with excessive bleeding, okay, excessive monthly bleeding. Now we expect that normally your menses should be from about 30 mils to about 80 mils, but some females may bleed more than 90 mils, and in such a situation we call it hypermenorrhea or menorrhagia. Then if you bleed less than, let's say, 20 mils, then you are suffering from hypomenorrhea. Now we expect that there's preparation of the uterus prior to implantation, if there's fertilization, for possible fertilization actually. But what will happen is that some people don't ovulate at all. But if you don't ovulate, then what will happen is that it could mean that there's follicular growth, but it will get arrested at a certain point in time. Okay, so that the Graafian follicle, which is the mature follicle containing the secondary oocyte, is not ovulated. In such a case, yes, granulosa cells, as they begin development, they will be producing, of course, estradiol, which will help in the initial thickening of the uterus. So when that happens, there wouldn't be any ovulation, but because there was initial thickening, although it was not complemented by progesterone, then what will happen is that there will be some kind of slight shedding of blood. So that one, you will see it as hypomenorrhea. Small blood will come out, and that is what we call anovulatory cycle. Such that yes, no blood actually, less blood actually came out. So one other thing too, which is actually a neoplasia, a benign growth, which can occur on any part of the uterus, is known as fibroid. As I said, it's non-malignant, it's non-cancerous, it's benign. But usually, depending on where it is going to implant, if it's going to implant around the posterior aspect of the fundus, okay, around this area, then that's where the problem tends to come in. because what will happen is that that's where the fetus will have to grow. But of course, the fetus can implant anywhere, which may pose less risk, okay, as far as placenta previa is concerned. So if it inserts in, let's say, it can insert in the fundic area, which is quite dangerous. But if it inserts in the mucosal area, okay, get into the muscle area, so between the mucosa, that's the endometrium, and the muscle can form over there, that's what we call submucosal fibroid. Then it can even happen in the muscle itself, that's the intramural or the intramuscular parts. Then it can even insert around below the serosa, subserosal fibroid, of course. Then we can also have what we call the pedunculated fibroid, fibroid. So we can have fibroids actually inserted in several areas as far as the uterus is concerned, but actually it's going to be benign. It's not cancerous. So that's was the the uterus. Now let's quickly look at the cervix. Now if you take the cervix, I told you that the cervix is the neck of the uterus. Okay, cervix is the neck of the uterus. There's the vagina, there's the cervix, and there's the body of the uterus. Now, one thing that I have to explain to you before I move on is that we have what you call the isthmus. Now, I told you that the isthmus is a narrow area between, of course, the cervix and the body of the uterus. Now, I told you that for the cervix, we are going to have external os, external orifice, okay, from the vagina into the cervix. And then we're also going to have what we call the internal os. Now, for the internal os, two internal osses have been identified. Now, we have what we call, this where my cursor is known as the histological internal os, and this one is known as the anatomical internal os. Now, between the anatomical internal os and the histological internal os, this area, this narrowest region, is known as the isthmic part, the isthmus. The isthmus. The word isthmus just has to do with narrow region over here. So that is what we are going to find with the cervix. Now this isthmus is very important. Why? Because it forms what we call the lower uterine segment. Now during enlargement of the fetus, then what happens is that there should be accommodation, okay, by what we call the uterus. And so this area will have to expand to accommodate the fetus, and therefore this isthmic part also forms what we call the lower uterine segment. All right. So as we said, that is what we find. Now, if you look at the cervix is going to have two parts. We have the part which is related to the vagina, and therefore we call it ectocervix. Then we have the part which is closer to the uterus, or quite proximal to the uterus, and therefore we call it endocervix. Then in between them, okay, there is that kind of junction between the ectocervix and the endocervix, which we call it the transformational zone. Now this so-called transformational zone can also be referred to as the squamo-columnar junction. Why? Because the ectocervix, because related to the vagina, will be endowed with stratified squamous non-keratinized epithelium. And then the endocervix, because related to the uterus, will have what we call columnar, simple columnar epithelium. Okay, so if you have this, therefore the junction, okay, where a lot of neoplasias or carcinomas of the cervix can actually take place, is known as the squamo-columnar junction. But there are some females who tend to abuse contraceptives quite early in their life, and therefore what happens is that yes, there will be actually the endocervix will actually grow into or move into the ectocervix, and that's what we call ectopy or eversion. Ectocervix growing into the endocervix. Okay, that's what the endocervix moving more into the ectocervix, ectopy. So if you tend to abuse it more, then that's what we are going to find over there. Now, one other thing too that we have to know is that I'm going to show you something. Okay, as we move on, I'll show you something we call Nabothian cysts, or Nabothian follicle. Now this kind of one, although it is a pathology, is a not normal thing that we expect to see, but what happens is that it tends to, if they are small, they tend to go on their own. Now they don't pose any clinical significance. I'm going to show you this kind of Nabothian cysts. Okay, all right, so that is with the cervix. Now one important thing that we have to know regarding the cervix as well as the body, or the corpus. So I told you that the cervix is just part of the uterus, and we also have the body of the uterus. Now depending on a particular state or the age or the reproductive state of an individual, we may have variations with the cervix and the body of the uterus. Their ratios may vary. So for an infant, you are going to see that we are going to have a lot of the parts of the cervix. Okay, so the cervix will be about twice as much as the body of the uterus, Yes, even as well as in pubertal age. Apart from being an infant, prior to being puberty, okay, being a child, yes, such phenomenon is what we are going to see. So the ratio will be, yes, between the body and the uterus will be 1:2, as you can see. Then, of course, if you grow around the pubertal age, then what will happen is that, yes, there will be that kind of variation. Around puberty, there will be that kind of variation. So generally, as you grow, getting to puberty, what will happen is that this one will be moving down, the body will be increasing, while the cells will become smaller. So almost equal proportion. Okay, just prior to puberty, or just around puberty, we are going to find a ratio of 1:1, and then later what will happen is there will be reversal. Okay, reversal, just after post-puberty there will be reversal, so that we have more of the body to that of the cervix, because of course at this point we expect that, yes, there should be implantation. So if there should be implantation, it's the corpus part which is going to receive it. So the corpus will be greater, so the ratio will be 2:1, just after puberty. So mainly, yes, in the reproductive age too, it may even increase further to even get to about 3:1 or even 4:1. But surprisingly, at menopause, it regresses back, and then eventually gets to a ratio of 1:1. So at menopause, what will happen is that the body to the cervix ratio will be roughly 1:1. Now I told you about the external os being, yes, the ostium. Now we said that now depending on whether you've given birth through the vagina or not, then the shape of the external os may vary. So this one is roughly oval shaped. It means that has not given birth through the vagina before. Okay, nulliparous. And this one, because the person has given birth through the vagina, it becomes slit-like. Okay, so that is the variations that you have to see. So whenever they give you the external os of any female, you have to just look at the slit. If the person has given birth through the vagina before, it becomes slit-like. Otherwise it will be this kind of oval shaped. So this is the epithelial tissue. So I told you that we are going to have, yes, of course, the ectocervix. Then we are also going to have, of course, the endocervix. Then in between them will be the transformational zone. Okay, that junction, transformational, or the squamous-columnar junction. Now over there too, we are going to have the Nabothian cysts, or the Nabothian follicles, which may form over here, although they are not normal and therefore pathological. They don't pose clinical significance. But one thing that you have to know is that, yes, you are going to find more of these ones in situations where the stratified squamous epithelium grows over the ectocervix. Okay, so if you have stratified squamous epithelium growing over, in the ectocervix, growing over the glandular epithelium, that's simple columnar epithelium of the endocervix, in such a case, then you have a more of the Nabothian cysts actually emerging. emerging. So that is it. That's it that we have. That's the ectocervix. Then of course you have the endocervix. Then of course the transformation zone or the squamo-columnar junction. Now, one thing too that I have to tell you is that by way of blood supply to what we call the cervix, it will be coming from what we call the descending cervical artery. Okay, we'll be giving it. Of course, the descending cervical artery is actually coming from what we call the uterine artery, which is a branch of the anterior division of the internal iliac artery. So mainly that one is what we are going to find. But of course, it will be drained by the corresponding vein. Mainly that is it. Now let's look at actually the uterine tube. The uterine tube can also be referred to as the sapiens. Yes, we can also refer to the uterine tube, as the fallopian tube. But remember that the cervix that we saw, very small, just about 3 centimeters long. The uterine tube is quite long. Okay, as you can see, the uterine tube is quite long, and it's roughly 10 to 12 centimeters long on average. Now this uterine tube, okay, is trumpet shaped, and the opening into, of course, the uterine cavity at the level of the conua is known as the ostium. So that's the ostium of the uterine tube. Then this is the lumen. So just like any of these tubular structures, it's also going to have 3 coats. Okay, it's going to have endometrium. It's going to have a mucous membrane, a mucosa. Then it's also going to have a muscular coat. But remember that, yes, as we saw in the case of vagina, yes, even in the uterus, the muscular coat will be fibromuscular. There will be high infiltration by what we call connective tissue, bioconnective tissue. So we are going to see that. And then again, it will have what you call the adventitia. The adventitia will also form part of it. So that is the uterine tube that we are going to find with it. Now the uterine tube is going to have 4 main parts. 4 main parts have been identified regarding the uterine tube. So from where it is going to have connection with the ovary, we are going to have the infundibular part. Now this infundibular part, yes, will have some finger-like projections, as you can see over here, which are known as fimbriae. So around the infundibulum, the terminal portion is fimbriated, okay, having these kind of fimbriae. And these fimbriae, one of them actually, or some of them, will actually have connection, especially prior to ovulation, will be moving around the ovary, surrounding around the ovary, so that the ovulated oocyte will be captured by the fimbriae. And that kind of fimbriae is regarded as fimbriae ovarica actually, or fimbriae ovarica actually. Now what will happen is that, yes, usually its diameter is about 1 centimeter long. Okay, that's one thing that we have to know about the infundibulum, having these kind of fimbriae. So once the fimbriae captures the oocyte, it will travel through this one, through what we call peristaltic action, the muscular contractions of the uterine tube, as well as ciliary action. Okay, so there will be cilia in the epithelial lining of the the sapiens or the fallopian tube. I will actually show you the epithelial lining. So there will be cilia which will be beating towards the uterine area. So in this area we have a lot of uterus. We have a lot of cilia to beat in the direction of the uterus. And then we also have this, it will get to this dilated portion over here, which we call it the ampulla of the uterus, ampulla of the uterus. Now this ampulla of the uterus is highly folded, which I'm going to show you, having this kind of honeycomb like appearance, so that I can actually slow down the movement of the oocyte, secondary oocyte. So that is this area where we expect that fertilization will take place. Why? Because it helps slow down the oocyte. But because it is having this honeycomb-like appearance, it also represents the area where, of course, the oocyte can get lost. can get out of sight of the spermatozoa. But of course there will be chemoattractants so that they can locate the oocyte wherever it is. Again, it is the same ampulla where of course ectopic pregnancies regarding the fallopian tube is concerned, and that's the tubal pregnancy. If tubal pregnancy occurs, yes, and if it's not taken care of, then it could actually result in rupture of this uterine tube. Okay, so actually over here we have this long portion being the ampulla of the uterine tube. It's actually about 5 centimeters long actually. Again, it's also going to represent the site for what we call gonorrheal salpingitis. So inflammation of the fallopian tube as regards gonorrheal infection will actually mainly occur over here. This is the commonest site, as well as what we call tubo-ovarian abscess. So tubo-ovarian abscess, more of it will form over here. Again, because of its highly folded nature, of course it's going to also have a substantial length as well, 5 centimeters long. Now we have this narrowest portion by way of diameter, narrowest portion, although it's quite longer, about 2 to 3 centimeters long. Then by the narrowest portion will be this interstitial part or the intramural part, which we are going to get to. So this interstitial part, which you find here, actually serves as what you call physiological sphincter to actually the uterine tube. Serves as a physiological sphincter to the uterine tube. Now it is the preferred site for tubectomy. So if you want to remove remove the fallopian tube, okay, you want to actually do it over here. Now remember that removal of uterus is known as hysterectomy. Okay, so removal of this will be tubectomy. But of course, if you cut this, then you have to ligate it, okay, around here. Then you tie it over there, so that of course if you have a female who doesn't want to conceive again, then of course you have to tie it over here so that there wouldn't be any implantation, because you have to go through this way to get it to this side. And of course the sperm tube will have to travel this way to come and meet the secondary oocyte over here. So that's the isthmic part, serving as a physiological sphincter. Now the one which actually serves as an anatomical sphincter is the intramural part, or the intrauterine part. Part of it is in the uterus, or the interstitial part. Now this interstitial part is the narrowest actually. That's why it's going to serve as an anatomical sphincter. So that's what we are going to find with it. But remember that when the secondary oocyte is ovulated, yes, it is going to be functional, it's going to be fertilizable in about 24 hours. So beyond 24 hours, yes, it will usually get resorbed, to get broken down actually. And if it gets fertilized, then it will take about 7 days to get implanted in the uterus. So that is what we are going to find regarding the salpins. Now with blood supply to what we call the salpins or the uterine tube, we are going to divide the uterine tube into what we call lateral third and then medial 2/3. Now the lateral third will be getting supply from what we call branches coming from what we call the ovarian artery. Then the medial 2/3 will be coming from branches from what we call the uterine artery. Then of course, with respect to drainage, they will be drained by corresponding veins. You can see uterine venous plexus, okay, will actually all the way come in and drain it, give off some drain. So it will drain through uterine venous plexus as well as into the ovarian veins. So that is that. But of course with nerve supply, yes, unlike the uterus that we saw from T10 to L1 segments levels through parasympathetic innervation, this one will be getting its innervation from T11 to T12, even as well as the L1 segment. That's what we are going to see. But remember, I've already indicated that the upper 2/3 of the vagina, yes, the entire uterus together with the fallopian tubes will actually be developing from what we call the Mullerian duct. So by way of this, now you can see, now this is actually showing you the ampulla of the uterine tube, highly folded, having this folded appearance, honeycomb appearance, so that it can slow down the movement of the oocyte, secondary oocyte. Now what we find over here is that there is epithelial lining. The epithelial lining is actually simple columnar epithelial tissue, but what happens is that some of the cells are bearing cilia. They are the tall columnar cells, and some of them do not bear cilia, and they are the secretory cells. These secretory cells are also known as PEG cells. So as I told you, with the help of the cilia, it will actually move the ovulated oocytes towards the uterine area. So it tells you that yes, from the infundibular part through to the ampulla part, there will be a lot of cilia. Okay, increase in cilia in that regard. But what happens is that yes, after implantation, the pre-implantation embryo will have to be nourished. Therefore, as you get to the ampulla, more secretory units will be coming. So cilia decreases, okay, from what we call the ampulla, from the infundibular to the ampullary region, okay, with the help of estrogen. So cilia development is influenced by estrogen. But these PEG cells, or the secretory cells, which are going to help nourish the pre-implantation embryo, or of course the oocyte as it travels along to the the secretory cells will be increasing along the length of the uterine tube towards the uterine region, the isthmic part, and of course to the intramural part. So that is that one. So this is actually the epithelial tissue. This is the connective tissue stroma, the lamina propria, as you can see over here. Now remember that the secretory units will be influenced, okay, high secretion will be under the influence of what we call progesterone. Progesterone will actually aid in that regard. All right, ladies and gentlemen, I hope you find this tutorial helpful. Thank you very much, and may God richly bless you. Now, look at this briefly. Now, for ectopic pregnancy, if it is happening outside the uterus, then we call it extrauterine ectopic pregnancy. So, like, it can happen in the ampulla region, it can happen even in the infundibular region. Yes, all these areas, or when the ovulation occurs and then the oocytes enters the peritoneum, then what happens is that if you have a sperm, viable sperm, it can actually get there and get it fertilized. So it can even happen in the abdomen. Yes, it can even happen inside the ovary as well. Okay, ovarian ectopic pregnancy. Then of course all these areas, yes, interstitial part of it. Then we can have what we call intrauterine ectopic pregnancy. Intrauterine ectopic pregnancy. So we said that it should, implantation should happen in actually the fundic part, posterior aspect of the fundic part. But if it happens somewhere quite dangerous, okay, even lower portion of the uterus, body of the uterus, even in the cervical region, then it becomes what we call intrauterine ectopic pregnancy, which poses a lot of threats, and that is what we call placenta previa. All right, so have a good day, and God richly bless you.